Hello, I'm Dr. James Gavin, Clinical Professor of Medicine at Emory University School of Medicine in Atlanta, Georgia, where I also serve as CEO and Chief Medical Officer of Healing Our Village, Incorporated. I'll be moderating this evening's program, The Role of Renal Glucose Excretion in Adults with Type 2 Diabetes. This program will provide an introduction to the pathophysiology of type 2 diabetes and the role of the kidney in glucose excretion. We will also be looking at a treatment option for adults with type 2 diabetes. Before we begin, I'd like to welcome our presenters. Both are wonderful colleagues and physicians with extensive experience in treating patients with type 2 diabetes. Dr. Charles Reasoner is a staff physician at Diabetes America and adjunct professor of medicine in the Division of Diabetes at the University of Texas Health Science Center in San Antonio, Texas. Dr. Pamela Kushner is a primary care physician and has been in private practice in Long Beach, California for more than 20 years. Welcome. During tonight's program, we will make an effort to answer the most common questions received from healthcare professionals. If your question is not addressed during the program, please submit using one of the following methods. If you are at a live venue, please direct all questions to the host representative, who will ensure that your question is submitted and answered promptly by the AstraZeneca Medical Information Team or by a field medical professional. If you're viewing the program online, please submit using the question box on the viewing console or contact medical information directly at 1-800-321-1335. AstraZeneca is committed to supporting physicians in managing adult patients with type 2 diabetes mellitus. So let's start with the underlying physiology of type 2 diabetes. Dr. Reasoner, would you please give us a brief overview?
Dr. Gavin, I'd be happy to. As we can see in this graphic, the pathophysiology of type 2 diabetes involves defects in multiple organs. In patients with type 2 diabetes, the body's responses to insulin are insufficient for both the uptake of glucose into skeletal muscle and suppression of endogenous glucose production, which occurs primarily in the liver. The pancreas is unable to compensate for these increasing demands for insulin, further contributing to hyperglycemia. In addition, renal glucose reabsorption adds to the core defects of type 2 diabetes, resulting in worsening chronic hyperglycemia in these patients. Now I would like to focus on the kidney and show how this adaptive response to conserving glucose for the body's energy needs becomes maladaptive in patients with type 2 diabetes. In this slide, we see that prolonged hyperglycemia, which is exacerbated by the continued and enhanced reabsorption of glucose, contributes to a vicious cycle of glucotoxicity that occurs in the progression of type 2 diabetes.
Now, Charlie, we know that the body has to maintain blood glucose concentration within a very narrow range throughout the day. What do we now know about the role of the kidney in handling glucose metabolism?
We've actually learned a lot. The kidneys contribute to the body's regulation of glucose through three primary mechanisms: production, utilization, and filtration reabsorption. In the post-absorptive state, the kidneys generate approximately the same amount of glucose as the liver. After an overnight fast, 75% to 80% of glucose released into the circulation is derived from the liver, and the remaining 20 to 25% is from the kidneys. In terms of glucose utilization, after an overnight fast, the kidneys utilize approximately 10% of all glucose used by the body. The kidneys can also influence glucose balance by returning glucose to the circulation via reabsorption of glucose from the glomerular filtrate. Each day, they filter roughly 180 liters of plasma and approximately 180 grams of glucose. Therefore, changes in renal tubular reabsorption may have a substantial impact on glucose homeostasis.
Thanks very much, Charlie. But could you give us some additional detail about how glucose is actually transported within the kidneys?
Jim, I'd be happy to. This slide illustrates glucose transport across a proximal tubule of a nephron and shows two major classes of glucose transporters. The facilitative glucose transporters, or GLUTs, are driven by the downward glucose concentration gradient across the plasma membrane. The sodium glucose cotransporters, or SGLTs, are driven by the sodium gradient created by the active sodium-potassium ATPase pump. GLUTs mediate the passive bidirectional transport of glucose, and 13 members of this family have been identified. Some GLUTs are responsive to insulin, others function in an insulin-independent manner. SGLTs mediate active unidirectional glucose transport. 6 members of this family have been identified, of which only SGLT1 and SGLT2 are well characterized. SGLT activity is not dependent on insulin.
Thanks, Charlie, for that informative overview. Now, I'd like for us to focus on a treatment option, Farxiga, or dapagliflozin, which is an SGLT2 inhibitor that was approved in January 2014 by the FDA. Please note that the U.S. full prescribing information, including the medication guide, is available from your AstraZeneca representative or by clicking the link at the bottom of your video player if you are viewing this program remotely. Dr. Kushner, would you please provide us with an introduction to Farxiga?
Of course. Farxiga is indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. It is not recommended for patients with type 1 diabetes mellitus or for the treatment of diabetic ketoacidosis. Farxiga is contraindicated in patients with a history of a serious hypersensitivity reaction to Farxiga. It's also contraindicated in patients with severe renal impairment, end-stage renal disease, or in patients on dialysis. As with all medications, it's important to review select important safety information. Farxiga causes intravascular volume contraction. This means symptomatic hypotension can occur after initiating Farxiga. This is a particular concern in patients with impaired renal function, that is, patients with an estimated glomerular filtration rate, or eGFR, less than 60 milliliters per minute, and also in elderly patients or patients on loop diuretics. Before initiating Farxiga in patients with one or more of these characteristics, clinicians should assess and correct volume status. After initiating therapy, patients should be monitored for signs and symptoms of hypotension. Farxiga increases serum creatinine and decreases eGFR. Elderly patients and patients with impaired renal function may be more susceptible to these changes. Adverse reactions related to renal function can occur after initiating Farxiga. Renal function should therefore be evaluated before initiating Farxiga and monitored periodically thereafter. Clinicians should discontinue Farxiga when the eGFR is persistently less than 60 milliliters per minute. Insulin and insulin secretagogues are known to cause hypoglycemia. So Farxiga can increase the risk of hypoglycemia when it's combined with these agents. Clinicians should consider a lower dose of insulin or an insulin secretagogue to reduce the risk of hypoglycemia when it's used in conjunction with Farxiga. Now let's go over the mechanism of action of Farxiga. SGLT2 is involved in glucose transport, as we heard. Specifically, SGLT2 actively removes glucose from the kidney filtrate and transports it back into the bloodstream. Farxiga inhibits SGLT2, reducing the amount of glucose that is reabsorbed by the body and thereby increasing the excretion of urinary glucose. In a pharmacodynamic study in patients with type 2 diabetes, treatment with Farxiga 10 milligram resulted in the excretion of approximately 70 grams of glucose in the urine per day. This corresponds to approximately 280 calories per day at week 12.
Thanks very much, Pam, for explaining the mechanism of action of Farxiga. But at this point, I'm sure our audience would like to hear about the clinical development program. Exactly what types of studies were included in the program?
Well, let me give you a quick summary of the studies that were done. The Farxiga clinical development program was made up of 24 phase 2 and phase 3 studies, and it included both placebo-controlled and active comparator designs. The program evaluated the safety and efficacy of dapagliflozin in a range of adult patients with type 2 diabetes. The study populations included drug-naive patients and patients receiving oral therapies or insulin-based regimens. And there were more than 11,000 adult patients who were randomized in these studies, and more than 6,000 of those patients received dapagliflozin.
Thanks for that information, Pam. Now, to begin our review of the clinical trial program, Charlie, could you walk us through the phase 3 trials that were conducted in the treatment-naive patients?
Dr. Gavin, I'd be happy